Okay. Once again, a pleasant good morning. Welcome to the 7th CPT activity of QP EMS service. Today, we'll be discussing about traumatic brain injury. My name is Janel Canaria. I'll be your presenter for today. Okay, traumatic brain injury. Traumatic brain injury is a big topic, especially in the pre-hospital setting. It's a very complex and challenging topic. So we will be discussing, or we have selected few learning objectives here that we will discuss in the traumatic brain injury. But firstly, I want to present my disclosure that I, as a presenter, or the presenter, doesn't have any actual or potential conflict of interest in relation to this presentation. Okay, these are the learning objectives. I'm hoping that you have read and somehow reviewed the attachment that I gave or I sent. That was an article, combination of different articles or research study. It's an evidence-based practice. I compiled all related pre-hospital research and studies to come up with our own reference or reading material. Okay, learning objectives: to define what is traumatic brain injury. Number 2, they describe the physiology of traumatic brain injury. Number 3, to list the H-bombs of traumatic brain injury. So you might be wondering and asking right now, why is it we're calling it as H-bombs? Okay, next, to explain the evidence-based management for airway, breathing, control, and circulatory, to include neurological issues for patients with severe TBI. And lastly, to mention the best transport or destination practices for patients with traumatic brain injury. So these are the things that we will be discussing today and answering at the end of the presentation. To start with, so we always start the presentation with a scenario. So let me just present to you this related scenario. A 30-year-old construction worker working at height around 15 meters high. The patient was found lying on the ground unresponsive. No one witnessed the incident. Initially, you were activated as an EMS, QP EMS ambulance. You were activated and you have received this information from the dispatcher that the patient has an open fracture of the left forearm, left leg, and bruising on the left side of the chest, or the head rather, on the temporal area, as per the information received from the medic on site. So what are the questions, stimulating questions that we will be answering at the end? What is your initial impression and diagnosis as early as now? Just receiving information, right? That's why it is important for us to receive information, as many as we can, in order for us to prepare. So with this information, what will be your differential diagnosis or your initial impression? What are the preparation that you will do? Next question, how will you assess and examine the patient? And number 3, what will be your treatment and management priority on this case? So we will answer this one at the end. Okay, let me just give you some information about traumatic brain injury. Traumatic brain injury remains an important cause of death and disability globally. Okay, there are around 60,000 TBI-related deaths in the United States reported in 2019. That's approximately 166 TBI-related deaths every day in US. While in some studies in Europe, there are around 300 hospital admissions and 12 deaths per 100,000 per year in Europe. So why we have the incident or statistics in US, same in Europe, also in Qatar. TBI is a common injury in Qatar. Half of the victims are adolescents and young adults. A quarter or 1/4 of this age group is severely injured. Mortality among them represent 1/5 of overall mortality. So these are some of the statistics and epidemiology of traumatic brain injury worldwide. Okay, what are the goals? Goals, as an EMS provider, we should know what are our main goals as an EMS provider or in the pre-hospital setting. One is the immediate care of the airway and breathing, preventing hypoxia and avoiding hypocapnia to hyperventilation. Okay. Prompt restoration and maintenance of hemodynamic stability by avoiding hypotension episode. Okay. Provide environment for the brain by preventing the increase in intracranial pressure. So you need to provide optimal environment. Take adequate and proper care of associated with injuries or other injuries. And lastly, transport the patient to the most appropriate multidisciplinary hospital. These are the goals of pre-hospital care. These are our goals as an EMS provider. So please take note of this. So traumatic brain injury. Traumatic brain injury is a form of acquired brain injury that occurs when a sudden trauma causes damage to the brain. So this is a very complex acute cerebral injury that can include regional or global edema and at the same time bleeding. So these injuries like brain edema and bleeding can occupy space inside a non-compliant cranium. It's like our skull is a non-expandable object where it will not release. So what will happen? It may contribute to intracranial hypertension and potential cerebral death. So that's the definition of traumatic brain injury. Okay, let's move on. Primary and secondary brain injury. There are two types of traumatic brain injury. The first one is the primary injury, and the second one is the secondary injury. Okay, knowing or having said that, we EMS providers, where can we take place? What are the rules in terms of traumatic brain injury? What can we do? We cannot do primarily something or anything on the primary injury, while on the secondary injury, this is where we're going to be focusing with. And the way to discuss with primary brain injury is the immediate damage to the brain or brain tissue that was acquired during the actual incident. It's either focal and diffuse. There are two types of primary brain injury, the focal and diffuse. Some of the focal brain injuries like cerebral hematoma or subdural hematoma, subarachnoid injury, the concussion, while diffuse traumatic brain injury, usually this is where coup, counter coup, or some form of traumatic brain injury. It happens when the brain rapidly shifts inside the skull. Most common, the coup and counter coup. And the secondary brain injury, this is usually the result of hypoxia and decreased perfusion to the brain. And some of the other contributing factors to secondary brain injury are hypotension, intracranial hypertension, hypocapnia, hypoxia, hypo and hypoglycemia. These elements or these factors can further contribute to the dying or let's say damaged and traumatized brain tissue already. So again, once again, for us, we cannot do much, or I would say we can't do anything on the actual injury that happens to the brain, but we can do a lot in the secondary brain injury to prevent secondary brain injury. So let's discuss. So in terms of time, usually primary brain injury and the secondary brain injury depends. The secondary brain injury usually occurs maybe seconds immediately or maybe after few days or few hours, right? Okay. As part of the traumatic brain injury, we will be discussing some physiology related to traumatic brain injury. So we'll just briefly discuss this physiology-related traumatic brain injury because we will be focusing more on the assessment and management of traumatic brain injury. So I have given you a lecture on this. I'm hoping you read it. It's it's included in the reading material or reference. Okay, following, we will discuss the following related to traumatic brain injury. Cerebral blood flow. Number 2, intracranial pressure, the Monroe-Kelly doctrine, and the cerebral herniation syndrome. Okay, cerebral blood flow. Actually, this is the cerebral blood flow is the net pressure gradient that drives oxygen to the brain or to the cerebral tissue. Cerebral blood flow is a function of cerebral perfusion pressure and the resistance to cerebral vascular bed. Let's simplify it. Cerebral blood flow is simply the pressure of the blood entering the brain. So that's CPP. Okay. CPP, please remember this. Cerebral blood flow is the difference between the mean arterial pressure and the ICP. We will have some details or some information related to cerebral blood flow, in particular, the cerebral perfusion pressure. Okay. Having said, cerebral perfusion pressure is the net gradient pressure that delivers or drives oxygen going to the brain. Okay. So related to CPP, just to give you some normal values, CPP normally is between 670 to 80 millimole of mercury, but here, let me just, here, at least you need more than 60 millimole of mercury in order to perfuse the brain adequately. Okay, while mean arterial pressure, though it says here 85 to 95 millimole of mercury, but similarly, in order to perfuse the brain adequately, at least the target is you need to have at least more than 60 millimole of mercury. It's the same thing. Though usually in head injury, you need to have a higher MAP. We will discuss later. And ICP, these are the normal values for ICP. Okay, normally there are some around 5 to 15 millimole of mercury, but anything that higher than this number will be detrimental or damaging to the brain. So anything above 15 is dangerous. Anything about 25 can lead to cerebral herniation. Okay, let me just clear this one so we can move on. Okay, let me just move on. Okay. Intracranial pressure. Next one. Intracranial pressure is a critical syndrome in which swelling of the brain forces portion of the brain tissues through the opening of the base of the skull, squeezing the brain stem and causing coma and eventually causing death. So what are the classic signs of increased intracranial pressure? Decreasing level of consciousness that progresses to trauma or to coma. Number 2, dilatation of the pupil and downward deviation of the eye on the same side of the injury. Okay, we call it unilateral pupillary dilation. So these are just some of the graphical representation. What will be the effect of intracranial pressure once it goes higher than the normal values? So this is excerpted from the Sanders Hospice Paramedic textbook. It says here, when the ICP increases over here on the cursor, so the pH will be decreased, the PCO2 will be increased. So symptoms that will appear to the patient, this is the clinical one in terms of laboratory or diagnostic tools. On the left side, decreased pH, increased PCO2. But clinically, patient will suffer from headache, nausea, vomiting, decreased level of consciousness, and decreased respiratory or abnormal respiratory rate. Another thing that we can measure is the decreased PO2. So it says here when ICP increases, CPP decreases. Makes sense. So when as CCP decreases, the blood vessels dilate. We'll discuss this one later. Okay. Increase intracranial pressure. When the ICP continues to increase, it will have some classic sign. How will you know, or how will we know whether the pressure is increasing or not? These are the common, or the most common, we call it the Cushing triad, or the Cushing syndrome, or the Cushing reflex. This what will happen if the ICP will increase. The blood pressure will increase, or the blood pressure will increase, correct? Why? Because the brain senses that because of the trauma, the brain is not perfusing well. So as a normal compensatory mechanism, the autonomic nervous system will be activated because it's sensing, okay, there's not enough blood to the brain because of the injury. So what will happen? Our body is good. Autonomic nervous system will sense it. So what will it do? It will increase the blood pressure. Somehow, then another effect of Cushing triad is irregular respiration, wherein continuous pressure on the brain will affect or damage the respiratory center, and heart rate. Well, maybe you are wondering how come there's a decreased heart rate. This is also a normal compensatory mechanism. I will discuss later on the next slide. Okay, so clinical progression of increased ICP. Eventually, when the ICP continues to increase, so automatically there will be an auto-regulation reflexes. I told you, the body will compensate, the body will react. So in order to increase cerebral perfusion pressure or decrease the ICP, what will our body will do? This is what will happen. The autonomic nervous system will, having said initially from the previous slide, the autonomic nervous system will sense that the brain is not perfusing properly or adequately. So he will activate the autonomic nervous system. Therefore, it will increase the systolic blood pressure, or systemic blood pressure. Then, however, on the other hand, the baroreceptors in the carotid and aorta will sense, oh, the blood pressure is too high. The blood pressure is too high, so I need to put signal or give signal to the brain to activate the parasympathetic, just to contradict the severe high blood pressure. Usually for traumatic brain injury, if you will note it, the patient will have increased BP as a compensatory mechanism to maintain the cerebral perfusion pressure. Okay, going back. So once the autonomic nervous system increases by increasing the blood pressure, then another compensatory mechanism, the baroreceptor, right? The baroreceptor will notice, oh, the BP is way too high. I need to activate the baroreceptor. Then I will activate the parasympathetic nervous system. The effect of the parasympathetic nervous system is what? Is the decreased heart rate to counter the blood pressure. Did you get it? Okay. So that's why you can see initially in traumatic brain injury, there will be increased blood pressure and decreased pulse rate because of this mechanism. We call it the auto-regulation. Then after some time, the ventilatory patterns will become abnormal as the herniation occurs. Okay? So let's move on. Hope you understand this. Let me just... Okay, let's move. Okay, a monocalist doctrine. This is just a brief information. Monocally doctrine, in this doctrine, it says there are only three components in the blood, in the brain, right? So there are only the blood, the brain, and the cerebral spinal fluid. So there are only three major components of the brain: blood, the brain tissue, and the cerebral spinal fluid. In this doctrine, it only explains that anything outside, like this one, you will see, anything outside the normal elements, like a mass, for example, there's a mass or there is a bleeding. So what will happen? The CSF and the venous blood will compensate, they will also be reduced. Same thing here, as the masses, the size of the masses expanded, the volume of the blood will decrease, the CSF will be decreased as well. So these two are also means of giving perfusion to the brain. So what will happen? The mass will occupy the brain, therefore the oxygen and the blood supply to the brain will be decreased. So this is just a simple explanation of CSF, of Morrow-Kelly doctrine. Okay, let me just clear this one, clear, and move on. Clear. Okay. Cerebral herniation syndrome is a clinical syndrome. Let's move on. It is a critical syndrome in which swelling of the brain forces the portion of the brain tissue to go down. You know, our skull is a non-expandable box. The only opening in the skull is at the base of the skull. Therefore, if there will be a blood, there will be a pressure inside the brain, it will squeeze the brain's tissue going to the brain stem, or it will squeeze the brain stem and causing coma and eventually death. Okay. What are the classic signs of cerebral herniation syndromes? There will be decreased level of consciousness that progresses to coma. Again, dilatation of the pupil and an outward downward deviation on the same side of the injury. Okay, we call it the unilateral pupillary dilation. However, on the lower extremity, we call it the contralateral paralysis or paresis. It always goes like that. If the injury is on the left side, the affected part or manifestation on the head will be on the same side. However, we call it the contralateral paralysis. Down below, in the lower and upper extremity, the signs and symptoms will be on the opposite side. So there will be decerebrate posturing, and also, in addition, having said, just mentioned the crushing reflex. So these are the classic signs of cerebral herniation syndrome. Okay, just to give you some notes, you want a screenshot on this. This is the actual specific brain herniation, affected brain structure. For example, if we have changes in the level of consciousness, the midbrain and the RAS are the one affected. If we have personality changes, it will be the frontal lobe which are affected. If we have abnormal ventilatory or some changes in the respiratory, the pons, which is the apnea center, and the medulla are the one affected. The corticate posturing, there's damage to the midbrain. The cerebrate, midbrain, bradycardia, and hypertension related to medulla or vasoactive center. And the seizure is a generalized seizure. These are accepted from the AN/EMT 2020. Okay? Oh, now, what are the 3H bombs of traumatic brain injury? This is one of the big topics that we will be discussing here. Okay, let me just check whether can you hear the volume. Okay, I'll just play. Okay, let's move on. So what are the 3H bombs? Hypoxia, hypotension, hyperventilation. Once again, what are the 3H bombs? Hypoxia, hypotension, and hyperventilation. To discuss further, I just want you to the 3H bombs of traumatic brain injury. Can everybody hear this? Okay, let me just start again. The 3H bombs of traumatic brain injury. Traumatic brain injury remains an important cause of death and disability globally. Nearly 3 million people experience traumatic brain injury every year. Identifying and extinguishing the 3H bombs of traumatic brain injury leads to twice survival among severe TBI patients and even 3 times survival among intubated TBI patients. What is traumatic brain injury? Traumatic brain injury is a blow to the head that disrupts normal function of the brain. What happens in the ambulance can improve survival. What are the 3H bombs of traumatic brain injury? The first H, hypoxia. Second H, hyperventilation. And the third H, hypotension. Hypoxia. Hypoxia is an oxygen deprivation to the brain. The treatment for hypoxia is the administration of high flow oxygen. The goal is to maintain an oxygen saturation of more than 90%. Hyperventilation is a rapid breathing. Hyperventilation kills brain neurons. The treatment for hyperventilation is through breathing mask. The goal is to maintain an ATCO2 target of 40 millimole of mercury and a ventilation rate of 10 breaths per minute. Lastly, the third H, hypotension, is a low blood pressure. The treatment is the IV fluid administration. The goal is to maintain a systolic blood pressure of more than 90 millimole of mercury. The 3H bombs of traumatic brain injury, excerpted from EPIC guidelines for adult traumatic brain injury. Okay, let me start. I'm hoping you understood a simple or a very brief introduction and information related to the 3H bombs of traumatic brain injury. Okay, now let's go on and continue. So I believe that again, I want to emphasize there are 3H bombs of traumatic brain injury: the hypoxia, hypotension, and hyperventilation. Okay, assessment and management of traumatic brain injury. So airway, breathing, circulation, disability, exposure, A, B, C, D, E. I love using this pattern of assessment and management to guide me. So each stage of the ABCD approach involves critical assessment or clinical assessment, investigation, and interventions. Usually, I use the practice of, we call it, just hold on. We call it A, assess, you diagnose, you intervene. I always use this pattern when I'm using the ABCD approach. So as we go along in each stage, I use the ADI. First, for example, in airway, I go to the airway, I need to assess. Then after assessing the airway, I need to diagnose what is the problem with the airway. Then afterwards, I need to intervene. So ADI, assess, diagnose, intervene. That's what we call it. Okay, please choose this pattern as well or practice in order to guide you in dealing with, especially with critical patients, ADI, ABCD approach. Okay. In the primary ABCD course, we need to look at manage exsanguinating bleeding early and aggressively. You might be wondering why I start with CABCD. As usual, if there are any exsanguinating, right? Life-threatening bleeding. We deal first with bleeding. Okay, this is a trauma patient, especially on traumatic brain injury. Any volume, any pressure, right? It depends, or the brain is depending on the perfusion, or perfusion rely on the pressure and the volume. So any or each RBC is needed for the volume, oxygen, and brain perfusion. Okay, A, airway. Let's talk about the airway. Airway, what is the main goal? The main goal is to prevent one of the H, hypoxia. Hypoxia in definition, by definition, anything less than 90%. When you put a patient SpO2 less than 90%, that's hypoxia by definition. So what is our goal? Simply as increase the SpO2 to more than 90%. Not even 94. The goal here is just keep it more than 90%. Okay? So in terms of airway, we do assess the airway, right? Airway plus C-spine control, as always, be the partner. So how you manage the airway to prevent hypoxia? Basic airway maneuvers, what do we use? Right? Jaw thrust maneuver, jaw lift maneuver in any trauma patient. And adjuncts, if the patient cannot maintain an open airway, we'll go with the basic airway adjuncts. Can be oropharyngeal, controversial the nasopharyngeal, but again, airway adjuncts from the basic level point of view, you start with the basic OPA, okay, or just merely opening the airway. In an advanced airway or in advanced procedure where the patient cannot maintain an open airway, or despite of your basic airway maneuvers, still the patient SpO2 is going down. And remember, guys, single episode of hypoxia doubles the rate of mortality of traumatic brain injury. Just a single episode of hypoxia or anything less than 90% SpO2 doubles the rate of mortality of TBI patient. Okay, so in intubation, usually there's an advanced provider. So what are the indications for intubation? Anything hypoxia that cannot be corrected by supplemental oxygen. The patient is hypoventilating despite of your effort on the basic airway adjuncts, but still the patient is hypoventilating or hypoventilating by himself. Okay, GCS, let's say less than 8. Some reference says less than 9. But at the end of the day, the most significant in terms of GCS is the changes from, for example, the patient used to be 11 or used to be 12. Suddenly it becomes 7. That's a big change in the GCS. So these are the type, or this is the type of patient that you need to consider intubation. So any or additional indication, anyone who is unable to maintain an adequate airway. So perhaps you need to do, especially with our helmet counterpart, RSI, just to protect the airway, especially with head injury. Okay, what are the ET tube consideration? Main goal is to avoid hypoxia. If you have considered intubation, is pre-oxygenate. Also, advanced provider, they are giving RSI or rapid sequence intubation or drug-induced, drug-assisted intubation. Prevent those type of medications that can cause vasodilatory effect, right? And in terms of resuscitation, in the point that you are intubating patient, make see to it in resuscitation, the IV fluids and the adrenergic medication are also on hand, okay? Breathing, let's go with breathing. Same again, same still. The main goal is to prevent or avoid hypoxia. So in terms of breathing, now you finish assessing the patient. He cannot maintain an open airway. Somehow you intubate him or you inserted an OPA because it's indicated. Now you're breathing. You assess the breathing. Obviously is not breathing by himself, right? So with that patient. But what are the sources of intervention in terms of correcting hypoxia in the breathing? So basic one, administer high flow of oxygen by a non-rebreather mask. If you need to do assisted ventilation via bag bulb mask or mask bulb, please do so. Or at the end, if you need to intubate him, intubate him. So the main goal is ETCO2, right? ETCO2 must strictly be maintained between 35 to 45. And the target is 40. So if you have at least tidal volume of 77 cc per kilogram, but at the end of the day, the ventilation rate must be adjusted based on the ETCO2. And if you're doing a basic one, you haven't attached it to ventilator, 10 breaths per minute per ventilation rate. Now the question here that I would like to ask, between an ETCO2 and an SpO2, right? Which one will you focus more, or will you be relying more? Because the goal here, I'd say, is 35 to 45 or 40, but the and the tidal volume or the rate is around 10 breaths per minute. So between ETCO2 monitoring or a parameter in engaging the ventilation versus the SpO2, I'll go more with the SpO2. Okay, then from there, because you don't want to make the patient become hypoxia. Okay, hyperventilation. Hyperventilation, what are the contraindications? Let's say, what are the bad things related to hyperventilation? So usually hyperventilation causes what? Vasoconstriction, cerebral vasoconstriction. Though, however, in the brain, it says when you do a vasoconstriction, it will decrease the intracranial pressure. So you're now in a dilemma. But in the new guidelines, they did not even recommend hyperventilation, because we EMS providers, when think about traumatic brain injury, we always think of, I need to hyperventilate. I need to hyperventilate. No, it's not anymore. Gone are the days that we are always thinking hyperventilation. Now, it did not even in the new guidelines, in new guidelines of traumatic brain injury, they even minimize discussing hyperventilation. Right? There are still some criteria when to do it, but there's no research studies that research studies that prove that hyperventilation is effective. It actually it shows opposite. It's detrimental and causes more damage to traumatic brain injury patients. Okay, what will happen if we are hyperventilating the patient? Okay, let's go with the drawing. Okay, let me just. So hyperventilation, automatic, it causes cerebral vasoconstriction. Look at the blood vessels here. What will happen? Decrease. It will constrict. It will become small, correct? So what will happen then? Because the notion of cerebral vasoconstriction, the notion is they will decrease the ICP. That's the notion, correct? We always think of that. But what will happen if you induce cerebral vasoconstriction, as what you can see here in the drawing? What will happen to the blood flow? It will decrease, right? Decrease blood flow, or CBF. Decrease cerebral perfusion pressure. So what are you doing now to your brain cells? Are you helping? No, you're not, because you are limiting, or you are decreasing the cerebral blood flow, right? So again, what is the effect of hyperventilation? So if you do a hyperventilation, you are removing out carbon dioxide. So what will happen here is decrease CO2 level, correct? So when you decrease CO2 level, right, what will happen? It will be alkaline. It will be alkalytic, right? It will become alkaline because you are blowing off EtCO2, right? The pH level will be decreased. So what will happen here? We call it the oxygen dissociation curve. So what will happen is the oxygen or the blood cells, the red blood cells or the blood oxygen-rich blood may be present, but it will not be consumed by the brain cells because of this alkaline environment. The affinity of the red blood cells will be reduced. Therefore, even though there's a blood supply to the brain, this small oxygen will not be consumed to the brain cells. So that's the effect of hyperventilation. Okay, I hope it's clear. Let me just. Okay. Let me just clear all the drawing then so we can proceed. Okay, to summarize it, hyperventilation, result of excessive hyperventilation will cause excess vasoconstriction, therefore decrease cerebral blood flow, therefore decreasing the ischemic injury, right? So once the brain is injured, same thing, it will end up having cerebral edema. So it's the same thing. You're also inducing injury, you're also inducing edema. Then therefore the mass will increase and eventually it will lead to intracranial pressure increase. Okay, that is the hyperventilation. That's why we do not encourage a routine or inadvertent hyperventilation anymore to TBI patient. Okay, circulation. What is the main goal? The next H or the third H is hypotension. Please avoid hypotension. Single episode of hypotension still also doubles the rate of mortality. What is the main goal? See, in some reference, they have a specific blood pressure. But in the new reference, or we call it the EPIC guidelines, the main goal is just to keep the systolic blood pressure more than 90 millimole of mercury. So what are the actions that we can do, right? In the pre-hospital setting? Manage the bleeding. Same thing. We have sanguinating bleeding. You should have corrected it from the beginning, okay? Protect patients against hypotension. How do we do that? Control the bleeding, insert IV fluids. So manage body temperature and prompt transfer and identification of internal hemorrhage. So if a multi-trauma system patient, you're dealing with a multi-trauma system patient, aside from traumatic brain injury, the patient has internal bleeding. So automatic, you immediately transport him. You cannot do anything there. But going back to our topic, your goal is to prevent the patient to become hypotensive. Okay. Okay. This is just, we mentioned, in order for us to maintain an accurate cerebral perfusion pressure, it depends upon two things: the mean arterial pressure and the ICP. Okay. Normally, in the mean arterial pressure, we have 60 millimole of mercury. That's enough or decent enough to perfuse the brain. But in patient with head injury, we need to make it higher, 85 to 95. Okay. Mean arterial pressure is just simply the blood flow or the pressure or the flow of blood going to the brain. So that's how the brain depends. So we need to maintain a mean arterial pressure more than 60. For anything with head injury, you need to maintain it a bit higher. But 60 will be a sufficient number. Okay, please look at this one. It's just a sketch or representation, a simple representation. Okay, having said, the CPP or the cerebral perfusion pressure depends on two things: Mean arterial pressure. I discussed about mean arterial pressure. This is the blood going to the brain. Simple as that. Okay, let's simplify the terminology. This is the blood going to the brain, the blood pressure. Then ICP, normally ICP we have 5 to 15, correct? But in traumatic brain injury, the ICP may increase to 20 millimole of mercury. Let's make it an example. This is just some representation, cartoon representation. Okay, I discussed about the MAP. Look at this, correct? MAP. So that's the blood going to the brain. What happened? And the normal CPP or MAP is within here. You can see here 60, the triangle, the line, 60, 65. Anything above this, we're okay. We are okay on this level. Anything more than 60, the mean arterial pressure is we're okay. Okay. So what will happen? So what if there's an ICP wherein increased intracranial pressure of more than 20 millimole of mercury? So as you can see in the drawing. So what will happen? The pressure, the ICP is the pressure within the brain. And I did mention that in the brain, there's no other opening except at the base of the skull. So look at this one. So if the ICP increases, what will happen? The pressure going down to the brain also decreases. So what happens with this mean arterial pressure? It will increase or it will decrease? Eventually, it will decrease to 50 or below. What is our main goal? At least a decent 60 millimole of mercury per mean arterial pressure in order to maintain an adequate cerebral perfusion pressure. Okay, this is just a brief representation of this CPP, MAP, and ICP. Okay, let's continue. That's why even though you might be wondering, Jay, we cannot measure the MAP or CPP at the field. Yes, I do understand. Our main goal is to have a blood pressure at least more than 90 millimole of mercury. So what is the relevance of knowing the MAP? So that you will know that MAP is secondary to or is a factor of blood pressure. I just gave you a simple explanation. Why do we need to maintain an MAP? This is because this is correlated to blood pressure and to avoid hypotension. Okay, circulation, give IV fluids at least 1 liter. If no effect, followed administration of isotonic fluids, sufficient rate and volume to keep systolic blood pressure of 90 millimole of mercury. Some books, even our ITLS, were saying 100 to 110, but here in the updates, anything, as long as it's more than 90 millimole of mercury, you're okay. Then another one, continue aggressive fluid resuscitation if no improvement. Okay. Some of the things under circulation related to traumatic brain injury, promising intervention that is being used right now, like the 3% hypertonic solution. It doesn't actually, the hypertonic solution doesn't actually reduce or increase the cerebral blood flow. What it does is hypertonic solution actually attracts fluids. So if you give fluids to hypertonic fluids, you know those excess fluids in the brain or in the brain tissue will go out to the vascular system. So this is the effect of hypertonic. And in the point that you need to use alpha adrenergic agonists like the norepinephrine to maintain an systolic blood pressure of 90 millimole of mercury. So some EMS services are doing that. And tranexamic acid, it's been tested and it's being recommended for moderate to severe traumatic brain injury secondary to blood loss. So these are the promising advanced intervention from other or updates in terms of traumatic brain injury. So let's go with still have a few more minutes. Disability, you need to check your baseline Glasgow Coma Scale, reassess every 5 minutes, okay, for TBI. Evaluate pupil. So what will you anticipate? Anisocoria, correct? Unequal pupil. check RBS, or we call it the blood glucose level. These are some of the basic things that we do under disability. Also check for other neurological abnormalities, the focal signs. I did mention about the focal signs. What are those samples of focal signs? We call it the contralateral paralysis and the unilateral pupillary dilation. These are some of the focal signs of traumatic brain injury or head injury in general. Disability, we need to correct hypoglycemia. In these guidelines, in our PCG says less than 60, but as in the new EPIC guidelines, they even recommend anything less than 70. We administer 50% ml or 50% dextrose. Yes, so one of the difference as well in the new versus our guidelines. In our guidelines, we say less than 70, but here, even less than 7, in our guidelines, it's less than 60, but in the EPIC guidelines, it's less than 70, but the same intervention, we administer the 50 ml. Then repeat blood sugar in 10 minutes, if still 70 milligram per deciliter, repeat another dose of dextrose water, okay? Exposure and transport. The patient should be fully transport and evaluate for extracranial injury during your transport, prevent heat loss. And the good thing with us here, anything priority 1, anything severe traumatic brain injury patient, we cannot think of something else except Hamad A&E or trauma center. You do not transfer him to, I will not use the word do not transfer him because we have some practices here, but preferably the only facility that can treat traumatic brain injury or any or the facility, anything that has a CT scan, anything that has a neurosurgical team, and anything that can monitor intracranial pressure is the best facility for any traumatic brain injury patient. Okay? So again, there's also some literature saying that helicopter had improved survival and greater chance of being discharged home despite of the longer times versus the ambulance. It's a case-to-case basis. In offshore, for our offshore colleagues, medevac is the only transportation. But we do have here as well. What can we do here? If you have a traumatic brain injury, we are the first responder. You know that the patient will benefit more if the patient will be transported immediately, especially our Raslapan colleagues in Dukan. You know, it's a TBI. You activate the life flight of Hamad, and they will be transported immediately. So study shows that air transport has a higher survival rate or good outcome in terms of traumatic brain injury patients. Okay, so that pretty much concludes my presentation. So what we're gonna do, before I will open the question and answer, I would like to present this case scenario again. Let me just review, then we will try to answer it. So a 30-year-old construction worker, same scenario, working on a 15 meters high. The patient was found lying on the ground unresponsive. No one witnessed the incident, or no witness. So from this report, initial report from the nurse saying their patient has an open fracture of the left forearm. So there also open fracture of the left leg, and there is some bruises or bruising on the left side of the head, which is the temporal side. As per information received from the medic on site, what is your initial impression and the differential diagnosis of the case upon receiving the information? Can someone volunteer answer this question for me, please? Mr. Aman, we are open for, not for Q&A, but for, we call it a participatory teaching or participation in terms of learning experience.
All right, okay. Thank you very much, Mr. J. So I just would like to open up who is volunteering for answering the first one. What is your initial impressions and differential diagnosis of the case upon receiving the information based on the scenario above? Please welcome to our participations. Maybe first one is from my side. Who is fond to volunteer from my side? Okay, or otherwise I will pick up randomly. I believe Mr. Milski want to share the idea.
Any volunteer will do.
Or volunteer. Anyone from my side, please.
Ronald, I'm seeing your face, Ronald. I'll just ask Ronald. Ronald, what is your impression and initial diagnosis of your patient?
Yes, Jay. It's a patient suffered from significant mechanism of injury
Correct.
because it's a fall from 15 meters high. That's very high. Okay, and based on the injury of the patient, he fell to his left side because his left forearm, left leg, and left side of the head is there's a injury. So he suffered from a head injury with other associated injury on the left left leg and left forearm.
Is this a critical patient?
It's a critical patient.
So would you
15 meters high is a significant mechanism of injury. So it's a priority one case. Priority one case.
So that's good. That's good. So how would you assess and examine the patient? Next one. Let's move on. Any volunteer? Mike? Or anything? Anyone who wants to volunteer? How would you assess and examine the patient? We will answer it. Don't worry. Ahmad, good morning. No, Ahmad Damawi. I just saw your face randomly.
CPD about traumatic brain injury.
Ahmad, where are you? Go ahead. Just share me your put some input. So how would you assess and examine the patient? Same as well. Sainal, want to contribute?
Okay, Jay. In my opinion, we will follow the protocol of RABC for this patient. We'll check for the response. We'll see that he's unresponsive. Then for the airway, we'll maintain him his airway by jaw thrust. Then fix it properly. Then for the breathing, we will check his breathing quality and the quantity, how many times the breathing and how is his breathing. Then for the circulation, of course, we have to manage the external bleeding that we found.
So
because this
technically,
patient has an open fracture of left arm, forearm, left leg, and also we'll see on the left side of the head.
Yes.
For the circulation, we will keep giving the IV and maintain the SPP more than 90. Means not giving what you call it, the fluid too much, but we just to maintain more than 90.
Right. Thank you.
And we will transfer him immediately to the nearest hospital. For my side, we will transfer to Hamad Hospital because this is we can say suspect TBI head injury.
Yes, correct.
Thank you.
Thank you very much. Thank you. Okay, Mike from Dukan. So I have called different team. Now, Mike from Dukan, what will be your treatment and management priority of this patient?
Hello, Jay. Good morning.
Yes. What will be your treatment and management priority?
Okay, of course, the treatment and priority of this patient is the airway. If we check the patient is not breathing, so we may use a basic airway adjunct. If in case it is not enough, can go on intubation. Then for the breathing, we can give HIV oxygenation just to
Yes.
maintain 90% SpO2
Yes.
or assisted ventilation.
Mhm.
Assisted ventilation.
If
Then
needed.
just not to hyperventilate the patient.
Exactly.
Excessive hyperventilation is not good, but there's what you mentioned. Sometimes we need to hyperventilate the patient,
Yes.
but not excessively.
Yes.
Now for the circulation, just insert IV, and just to maintain systolic blood pressure of 90.
At least more than 90.
More than 90.
Yeah.
As you mentioned, their textbook mentioned 100 to 110, but at least in this case, it's more than 90 is enough. And for the disability, we can check the RBS of the patient. If it is less than 70, we can give dextrose IV, that is 50%. Then we check after 10 minutes. If in case still less than 70, we can repeat one time.
Yes.
And then transport the patient to the
Correct.
hospital.
Correct. So to summarize what Mike had answered, technically we are focusing on the 3H bombs, correct? Prevent hypoxia, avoid hyperventilation, avoid hypotension, and we did mention additional H will be avoid hypoglycemia. Thank you very much, Mike. So that summarizes what we use our treatment priority. Same thing. So this is just to show you the answer actually. So this is the actual details of the patient. So you have your scene safety, the patient responding to pain pool, CABC, airway plus C-spine. Patient cannot maintain his own airway, snoring and sound noted. Breathing, rapid and shallow, 20 breaths per minute, 25. SpO2 is 90. Clear breath sound, symmetrical chest wall movement. Circulation, there is a slow, regular, palpable pulse. Positive bleeding on the upper and lower extremities. BP 110/65, pulse rate 56, warm, dry. Disability, GCS of 8, RBS of 78, positive anisocoria or dilated pupil on the left eye. Temperature is 37 degrees. Then exposure, bruises and left hematoma, and fracture of the left upper arm and left lower leg. So obviously the transport will transport him. In your assessment, in your continuous assessment, again, we call it the ongoing exam, reassess ABC, reassess the intervention, vital signs. This is a serious patient. We check it every 5 minutes. Okay. So summary. So we have identified ways, identification and prevention of secondary brain injury. We have discussed it. We also discussed the 3H bombs of traumatic brain injury. And what are those? Hypoxia, hyperventilation, and hypotension are 3H bombs. We discussed about the ABCD approach to TBI, and we also mentioned about the trauma, the hospital or the receiving facility in related to outcome to TBI patient. So that concludes my presentation, gentlemen. Now we will open the question and answer portion.